So, a very good afternoon to all our doctors on the call today. My name is Jifa Adeku, Medical Science Liaison here at Symbiotica. I think we should give another minute for others to join, then we can start. Thank you. Okay, thank you so much for Thank you so much for joining today's CPD. We are really happy to have you on the call. As I mentioned earlier, my name is Jifa Adeku, Medical Science Liaison here at Symbiotica. Today we'll be having a very interesting conversation, and I'm glad to let you also know that we have in here Dr. Francis Adai. He will be talking on the role of basal insulin in the management of diabetes, overcoming inertia in early insulinization. So I'll give a brief profile about our speaker or our facilitator today, and then we'll go straight into his presentation. Feel free to type in your questions and we'll address all the questions at the end of the presentation. We really want this interaction to be very interactive, yes, so that everybody goes away with gleaning to some insights or experience. So we are at your beck and call. Feel free to ask your questions, and at the right time, would answer all your questions. So, a brief profile about our facilitator today, Dr. Francis Adai. is a highly experienced medical consultant, family physician, and diabetologist with over 20 years of clinical experience. He's committed to delivering comprehensive patient-centered care through collaborative and team-based approach with an emphasis on preventive and curative medicine. He's currently the head of medical services at the Focus Orthopedic Hospital at Pantine, and he'll be talking on the role of basal insulin in the management of diabetes, overcoming inertia early insulinization. Dr. Day, you have the floor. Thank you so much for agreeing to talk on this topic. If you can unmute, please.
Thank you, Jifa. Right. Can you hear me?
Yes, I can hear you loud and clear.
All right. Thank you for those kind words from you. And good afternoon, colleagues. Um, I'm so pleased to facilitate this afternoon's presentation. And if Prince can allow me, or Jifa, you can allow me to share my screen, I'll be most grateful.
Kindly share your screen. You can do that. Just
Right.
it's
Can you
not
see my
shared.
screen?
No, it's not shared. So just share it and then we'll bring it in the stream.
Okay, because I'm sharing it now. Okay, just because it's telling me the browser has blocked your screen. Click the screen icon in your address bar to allow access. I'm not too sure. Okay, can you see my screen now? Hello, Prince. Can you see my screen?
We can see it.
All right, thank you. Good afternoon once again, colleagues. Um, and Jifa, once again, thanks for the opportunity. So this afternoon, I'm going to talk about the role of basal insulin in the management of diabetes, as Jifa rightly said. But then my emphasis will be more on type 2 diabetes because we can use basal insulin in pregnancy as well. And then we will later look at what inertia is, both clinical and then on the part of the patient, and then how to overcome it. So I'll start my presentation with this disclaimer. So what I cease to do this afternoon is purely to enhance our clinical practice and therefore help promote patient outcomes. I have no financial interest in Biosymbiotic or Sanofi. So I want to start this afternoon's presentation with this question. In your practice, how long does it usually take for diagnosis of your patients with type 2 diabetes and when you initiate insulin in them? Is it 1 to 3 years, 3 to 6 years, 6 to 9 years, or more than that? Please keep this question in mind. I also want to present to us a case scenario of a pre-op patient who was being optimized for surgery. The patient was being worked up for posterior spinal fusion. This is a 68-year-old who has had some low back issues She has a history of hypertension and bronchial asthma, mainly intermittent asthma. She also has a family history of type 2 diabetes. But significantly, during her workup, it was realized that her random blood sugar was 15.6 millimoles per liter, and her A1C, or what we call the glycated hemoglobin or HbA1c, was 10.8%. She was overweight but not obese. Her extremities essentially look normal. So my question to us is, will Madam Ajua Mensah need insulin as part of her management? We'll revisit Madam Ajua Mensah, so please keep it in mind. So my business for today will be in 4 sections. We'll be looking at the pathophysiologic basis of when it comes to deterioration of type 2 diabetes, the pathophysiologic basis, and then the role or benefits of basal insulin initiation. And then we'll look at the evidence thereof that supports basal insulin initiation. And with all this knowledge, we still have a challenge in when and how to initiate insulin. So we'll look at what the challenges are and how to get over them, and then we'll summarize with some take-home message. So my presentation will follow this 4 main outline. So I'll start with, I'm really not going to go into what diabetes is and all that, but we all know that type 2 diabetes or any form of diabetes is an insulin problem. I know other hormones like glucagon, myelin, and the rest plays a role, but the main thing, the main drive of high sugar levels in our blood is an insulin problem. Okay, so we want to look at what is normal and what happens in patients with type 2 diabetes. So when a normal individual is infused or ingests glucose, this is what happens. Okay, when you have glucose in blood, we tend to have 2 phases of insulin secretion. The first phase is a surge, which is like a spike, and this happens within 1 to 2 minutes of glucose exposure in our blood. Okay, and this first phase can last up to 10 minutes. Following the first phase, we have the second phase, which kind of plateaus and then declines gradually. The second phase usually will start from like 10 minutes and it can last for hours, up to about 2 hours. Okay. Now, what the first phase does is that the first phase of insulin secretion helps to control both prandial and postprandial glucose. Okay. The second phase will mainly help control what we call hepatic glucose output. Okay, so hepatic glucose output, you're looking at the role of insulin in breakdown of glycogen. Okay, you're looking at the role of insulin in the synthesis of glucose, what we call gluconeogenesis from other substrates like amino acid and all the likes. So the second phase will usually help control hepatic glucose output. Now, let's see what happens in patients with type 2 diabetes. What happens in patients with type 2 diabetes is that this phase that we're talking about tends to be delayed in patients with type 2 diabetes, okay? And then over time, it gets blunted. We don't get the spikes that we see in normal individuals. And over time, it completely gets lost. And that is what happened. So then you tend to have both prandial and postprandial sugars going up. Okay, I must say that it starts early on with postprandials, and then over time we tend to have our fastings also going up. So please bear this in mind that when it comes to type 2 diabetes, initially the control may be very good when it comes to anti-diabetic agents or glucose lowering agents. Initially may be good, but over time the control gets poorer and poorer, and therefore the endogenous insulin secretion that is being affected is just not enough to give you the glucose control that you need. And so you may get to a point where you bring some exogenous insulin to top up the endogenous insulin that the body is producing. Please keep this in mind. And I must say that this has to be taught very early in the diagnosis of our patient. You don't have to wait till when the patient is deteriorating. That is when you talk about this pathophysiologic process. It has to be taught very, very early from the onset of diagnosis, and then in the course of care of the patient, we have to reinforce this so that when it comes to a time when we have to introduce exogenous insulin, the patient will not refuse. It's very, very important. So please keep this in mind. Again, this is another slide trying to explain what happens in type 2 diabetes. And again, it's all about time. Okay. So right from pre-diabetes stage to diabetes, especially in obese and overweight individuals, insulin resistance exists. Okay. And once insulin resistance exists, initially there will be some amount of beta cell function that will help regulate sugars. But over time, this beta cell function and its activity is lost, and therefore your insulin levels also go down. You remember what I shared from the first slide, okay? And as this happens, initially you will have some raised postprandials, but over time, what really contributes to poor control are your fastings. Again, this slide is important for us to appreciate why we start augmentation of oral medications with basal insulin. We don't start with any form of insulin. Remember that as time goes by, initially postprandials will be high, but with time, what really controls or contributes most to poor glucose control is the fasting. And therefore, you need basal and no other insulin. So please remember this slide as well. It's so important in our discussion today. So what happens? Again, this is another graph depicting that initially you may have very good beta cell function, but over time, classically, within some 5 to 6 years, your beta cells begin to decline. And remember that these beta cells are the main site of production when it comes to insulin. We know they get destroyed. The very high blood glucose, what we call glucose toxicity, destroys the beta cells further. The very high lipid turnover, triglycerides, what we call lipotoxicity, destroys the beta cell further. We also know about apoptosis and all that. So what happens in type 2 diabetes is actually over time, the function and beta cell mass all decline. Function and beta cell mass decline. And therefore, your agents that appear to be working with time will decline. And we saw this in the UKPDS, that at 6 years, more than 50% of patients needed insulin for good control to get their fasting plasma glucose below or equal to 6 millimoles. So please remember this pathophysiologic basis in type 2 diabetes. So within phase 1, there may be about some 50% function, okay? Over time, phase 2, about 25% function. In phase 3, where everything is lost, virtually you have a type 2 now becoming like a type 1. And so all your oral agents, apart from SGLT2, that work through insulin pathways will no longer work. And therefore, the patient definitely will need insulin. You may even progress from your basal insulin to basal bolus or premix or something. But please remember this, okay? And then also remember that close to 50% of type 2 clients that we see at the time of diagnosis, they've already lost about 50% of their beta cell function. And therefore, for some patients, right from diagnosis, you may need insulin for tighter control. You may not have to do a sequential treatment by adding on. No. So please remember this, okay? So this forms or this informs us why a patient may need a basal insulin at a point, or a patient definitely need insulin from the onset, okay? Again, this graph depicts the fact that when we take from UKPDS and then the ADOPT trial, when you take your oral agents and even insulin itself and conventional treatment. So conventional treatment here, you are looking at sequential treatment. So from the time of diagnosis, you realize that these agents will give you very good control, right? A1Cs even below 6.5%. But close to 2 years on, you see the sugars going up. So it tells you that your agents begin to fail, even including conventional treatment. Okay. So your sulfonylureas, your biguanide, metformin will begin to fail over time, and you have to intensify treatment. Okay. And the same thing in adults where your glitazones, in this case was glitazone, metformin, and gemclamide were used in the trials. Initially, they worked because you have some preserved beta cell function, okay, and therefore they work. But over time, you lose your glycemic control. That is what happens. But why are we talking about all this? Why do we need this knowledge? We need this knowledge because if we delay the start of insulin when it's indicated, it leads to complications. And that is what we don't want to see in our patients with diabetes. It leads to both acute and chronic complications. I'm not going to dwell on the acute complications. I'm not going to talk about the DKs. I'm not going to talk about the HHS, and I'm not going to talk about hyperglycemic state, but I'm going to dwell a little bit on the chronic complications. Okay. So please do not hold back augmentation, insulin augmentation when a patient needs it, because we have the understanding that initially things may look good for some people. For some patients, right from day one, you know that they've lost 50%, close to 50% of their beta cell function and mass, and therefore, right from diagnosis, they need insulin. Okay, for some, it may come on later, as I have shown you or demonstrated. We know that poorly managed or controlled diabetes leads to both microvascular and macrovascular complications. The microvascular complications, we're looking at complications in the eyes, what we call retinopathy. We're looking at complications in the kidneys, what we call diabetes kidney disease or diabetes nephropathy. And then we look at complications in the nerves, mainly the peripheral nerves. And then over time, you can have other nerves also being affected, the autonomic, and then in the splanchnic nerves and all that. So please remember that if we don't control the diabetes very well, it leads to both micro and macrovascular complications. The micro as high as 30%. Okay. Now, when we control our sugars very well, with just 1% drop in A1C, we can reduce these microvascular complications as demonstrated in the United Kingdom progressive study into type 2 diabetes. You can drop microvascular complications by a whopping 37%. Okay. You can drop other macrovascular complications like heart failure, myocardial infarction, and strokes as well. Diabetes, as we know, is one of the leading cause of lower extremity amputation, even more than road traffic accidents. Okay. So if we control them very well, prevent the foot ulcers and all that, we'll be able to reduce below-knee amputations by as high as 43%. So we don't really have to delay adequate control in our patients. You don't have to keep adding medications. Okay. If 2 or 3 drugs will not work, please remember that 4 will never work. We'll come to that very soon. Again, let me touch on the glycemic pentad. Every form of high sugar is of concern, whether it's from fasting plasma glucose, postprandial glucose, or what we call glucose variability, or even low sugars. We know from clinical trials that when you have just 1% rise of A1C above normal, so you're looking at 8%, 9%, you can have increase in cardiovascular risk by as high as 18%. Postprandials are as important as fasting plasma glucose. So we don't just look at fastings. When we're managing our patients, we need to look at both their sugars after food, mainly 2 hours after food, and their pre-meal sugars. So you look at both prandial and postprandial. You don't just concentrate on fasting plasma glucose. The other thing we need to look at are glucose variabilities. Very, very important, because when you have a patient with glucose or glycemic variability, it predicts coronary artery disease. And it's very, very important. The same thing with hypoglycemia. Hypoglycemia can lead to arrhythmias and all that, and it increases acute cardiovascular events by as high as 79%. So you want to mimic the normal physiologic state of the patient without causing extremely high or lows. Please, let's bear this in mind. And remember that when it comes to HbA1c, what contributes to your glycated hemoglobin, barring any hemoglobinopathies, anemia or polycythemia, are mainly your fasting plasma glucose and postprandial glucose. These two averages your A1C. And I must say that they have different contributions when it comes to our A1C, and we'll see that shortly. The good news is that when we intensify treatment very well and prevent glucotoxicity and lipotoxicity, we can actually preserve beta cell function. And this was demonstrated in a small trial, okay, in Southwestern study, as we call it. And within just early intensification with insulin and metformin, within just but put 3.5 years, realized that beta cell function was highly preserved. Okay. And early intensification is so important that if you do that and do it well, as opposed to sequential treatment, again, in the verified trial where metformin was combined with vildagliptin, it demonstrated the need for early intensification. So now the emphasis is no longer on sequential treatment. Oh, let me start with metformin. The patient is not doing well. You add on sulfonylurea, the patient is not doing well. Oh, let me wait. You are not adding on insulin. You are waiting. No. If you do that, you expose the beta cells further to glucotoxicity and lipotoxicity and other form of oxidative pathways that destroys the beta cell function and beta cell mass. So you don't have to wait. Okay. I didn't include the verified trial in this presentation, but we can do further reading on that, where vildagliptin was combined with metformin for early intensification. So we know what the evidence is. Okay, so please let's bear in mind the pathophysiologic basis, what happens if we delay intensification, and the benefits if we do proper intensification of treatment. Again, the benefits of early tide control from the UKPDS 10 years post-trial follow-up demonstrates this clearly. If you compare the intensive versus those who had conventional treatment, what we call the sequential treatment, you realize that in terms of drop in microvascular complications was 25%, okay, as they were followed up. So we have the evidence. We have the evidence. It's significant drop in microvascular complications and other endpoints of diabetes control. And then remember that the follow-up tells us that there's also what we call the legacy effects of early intensification. So if you intensify patients very early, okay, you tend to have better outcomes than when you delay. So we've looked at the pathophysiologic basis and the benefits of what basal insulin initiation can bring. Okay. Now we want to look at some further evidence and then look at how we can initiate basal insulin. What has research shown us? Research has shown that there are 4 major issues that we need to talk about when it comes to managing patients with diabetes. There's what we call clinical inertia to initiate insulin. And this, evidence has shown, okay, there's also limited knowledge among healthcare providers when it comes to how to even initiate insulin and then titrate it, okay? And then also lack of guidelines. I'm happy now we've been able to launch and have our Ghana diabetes treatment guidelines. And then lastly, poor patient adherence. So when it comes to augmentation of management with insulin. There are the patient factors and then also the provider factors. Okay, so let's bear this in mind. And studies have proved all these that I'm talking about. Please remember that when it comes to managing diabetes, as I said from the beginning, diabetes is an insulin problem. And in terms of gain in glycated hemoglobin, the most potent agent is still insulin. It is only insulin that within 3 months, you can drop glycated hemoglobin by 2.5% or more. So if you have a patient with a baseline insulin at the time of diagnosis of 9% or more, definitely, if you want to add these drugs, then right from the beginning, that patient will need about 3 drugs. So let's say you are doing metformin with a DPP4, you can gain about 2.5, and then an SGLT2, then you can gain about 3.5, or anything between 2 to 3.5. So a patient with a baseline, if it is not contraindicated, if there are no confounding factors, a patient with a baseline glycated hemoglobin of 9% or more will definitely need 3 drugs. Okay. Now, if the patient has A1C 9% or more and is symptomatic, or the patient is on admission, definitely among those 3 drugs, one of them should be insulin for tight control. Okay, you don't have to do conventional treatment by starting with one and adding on. You can get away if the baseline A1C is, let's say, 8%. Then when you do any of these monotherapies within a space of 3 months, you can drop the A1C from 8% to 7% or 6.5. But please don't ever put a patient with a baseline A1C of more than 9% on monotherapy. Never do that. That's suicidal. Okay, that's suicidal. Or even dual therapy. Some you may get away with dual therapy, but for majority, they will need triple therapy. And as they get better, you reduce that. So please remember that insulin is still the most potent anti-diabetic agent. Again, this slide demonstrates or reinforces the fact that insulin is an important component of type 2 diabetes management. And if you look at the pre-treatment and post-treatment, so you have 2 oral anti-diabetic drugs, you have 3, you have 4, and then you have insulin. Now, look at the last column where insulin was initiated. Okay, and look at the A1C difference from the pre-treatment to the post-treatment, a whopping 1.3% difference. Now, look at a patient who was diagnosed even on 4 medications. Look at the difference. So what this tells us is that when 2 drugs fail, please don't keep adding on, because the beta cell function or beta cell mass, as we saw in the pathophysiology basis, will not come back. And therefore, so many oral drugs you are giving to that patient will do very little. Because look at what 4 drugs did in pre-treatment and post-treatment phase. Just 0.2% difference. So we are leaving the patient in a prolonged state of complications. And remember that anytime glycated hemoglobin gets to 8.5% and above, as demonstrated in the UKPDS, that is when the microvascular complications begin. That is when the microvascular complications begin. So when we keep these patients on 3, 4 drugs and they are still recording high preprandial or prandial and postprandial sugars, we are not helping them. They have to be augmented. Please, let's remember this, okay? Right. Now, when it comes to basal insulin, this is a head-to-head study with biaspart and then insulin glargine. I'll come to how to initiate basal insulin. From this head-to-head study, in what we call a 1 mg study, where 469 insulin-naive patients with type 2 diabetes with inadequate control on oral agents were randomized and began on treatment. Okay, so in the biaspart arm, they had metformin and glimepiride, and biaspart was added to their dinner, so pre-dinner, and then the glargine arm, they had glargine before bedtime added onto their metformin, and the outcomes, we saw improvement in just about 4 weeks. Okay, so let's look at what the outcomes were. They were comparable. Okay, now there was reduction from baseline at 26 weeks, and if you look at the A1C drop, the biaspart arm had almost up to 1.4, whilst the glargine arm had up to about 2.5. So they both work, and we see some supporting evidence to that effect. Okay, this is another representation of what I just spoke about. So the biaspart was when it came to the postprandial glucose control, it was shown in the 1 mixed trial that when it comes to postprandial glucose control, the biaspart had a little edge over glargine. Okay. Again, this is the preferred study where biaspart versus or analog, what we call the basal bolus. So basal bolus is another treatment option available to us where you have a patient failing, where you have high prandial and postprandial. When you have very high postprandials, most often your basal insulins, especially the glargines, may not work. Okay, but you need the glargine in addition to other agents. Because of time, I can't go over all these clinical trials. So what is the rationale for initiating insulins when it comes to basal insulin? Remember what I said from the pathophysiologic basis. When even before diagnosis, there's some form of impaired glucose tolerance from insulin resistance. So initially, from the early onset, you have some rise in postprandials. But as beta cell fails, as beta cell mass deteriorates, what contributes to poor glycemic control are the fastings. Is the fasting blood sugar. So when you are fixing, you fix the fasting first. You want to control hepatic glucose outputs. So important. Because if you don't fix the fasting, your A1C will keep deteriorating. And that is what this slide tries to depict, looking at healthy subjects and then patients with type 2 diabetes. Okay, so the first slide that I show in normal individuals, the first phase and the second phase of insulin in healthy. Now, in patients with type 2 diabetes, we know that initially it is delayed, and then over time it is blunted, and over time it is lost. That is what happens. It is lost, and this leads to hyperglycemia with elevated fasting plasma glucose. So if there's anything to fix from the onset, you fix the control with basal insulin. And that is how come for most basal insulins, we see that you give it at night. When you give it at night, it's so effective in controlling early morning hepatic glucose output. So then you are regulating how much is coming out from gluconeogenesis. You are regulating how much is coming out from glycogenolysis. Okay, you are regulating how much, you are improving how much glucose is taken into the peripheral cells by introducing your basal insulin. And this is very, very important. Okay, so this is what happens, and you have to fix the fasting first, and that is why you need basal insulin. Again, these are several trials. They treat to target the inside, the Apollo, the initiate, observational. These are things we can do further reading of. Okay, so this clinical trials actually demonstrated that basal insulin alone lowers high baseline A1C to near normal, and this is over 2 decades. Okay, it's so important because if you look at baseline and when the study ended, and these were clinical trials with basal insulin. If you look at the A1C differences, it's as high as 2.0. So when you have a patient failing, where A1Cs are going above 8.5%, Please, if you don't have any evidence of very high postprandials in the very late phase where you're looking at phase 3, always start with basal insulin. Augment, don't stop the orals unless you have evidence that the person is in phase 3 and therefore drugs like sulfonylureas, because they are insulin secretagogues, will not work, where you hold them back. Please use the doses all right, but augment the oral agent very early with basal insulin. And this clinical trials supports why you have to. It's so important, so important. Okay, and you do this and you reduce hypoglycemia. Okay, so this slide confirms what I've been talking about. Okay, so the gray area, you see postprandial glucose, and then the navy blue, you see fasting plasma glucose. So at very bad A1C, so let's take at 10.2% or more, you see that what contributes most to the glycated hemoglobin is fasting plasma glucose. Okay. It's not too bad controls. Like I said, in the early onset, what contributes are postprandial. So when our patients are deteriorating, what you need is basal insulin. Okay, and most patients, if you see the A1C worsening, 8.5% and above, please, if they are on 2 drugs at maximum doses, if really manage their lifestyle very well, they are eating and everything on point, please know that they are failing. Okay, know that they are failing, and you don't delay augmentation of their orals with insulin on time, and you start with basal. Okay, and this Monnier et al. Study done as far back as 2003 and published in Diabetes Care supports this. So we now know why we have to start with basal, and we have the evidence to support that. Now let's come to the insulin therapy itself. Who are those who benefit from? The list is tall. Like I said, or as I've been emphasizing, patients who have demonstrated poor control, that is unsatisfactory glycemic control, and they are on optimal dose of 2 or 3 drugs. Please don't add on a 4th oral drug. Don't ever do that to your patients. They are on 2 or 3 optimal, which means they are at maximum doses. The patient is doing metformin 1 gram BD. Let's say the patient is on dimicron. You've done 60. Please, 90 will not work. And don't push the metformin to 3 grams. Keep it at 2. You are on, let's say, pioglitazone. You are doing sulfonylurea. You are doing your glitazone and metformin, and they are failing. Please don't add on a 4th drug. Okay, patient is on SGLT2, like dapagliflozin, and pagliflozin is on metformin, is on sulfonylurea, A1Cs. The patient says, I don't know what I'm doing, but my sugars are not getting better. Please don't keep adding on. They are candidates for early intensification where you add basal insulin to their agents. And like I mentioned earlier on, at the time of diagnosis, control is very poor. The patient has not even been on treatment. A1C is above 9%. Patient definitely needs 3 drugs. And when they are symptomatic, one has to be insulin. Okay. Now you have patients presenting to you with complications. That is not when you put them on metformin. Metformin, one of the side effects of metformin is lactic acidosis. We hardly see this in clinical practice, but in the face of hypoxic state, very severe infection, some bad MI, okay, some very bad pulmonary infection. That is not when you're going to put a patient on metformin. They need insulin. So do insulin, and when they get better, you can, okay. And then pre-op state, patient scheduled for surgery and pre-optimization, and again in pregnancy. These are all indications for insulin use. Okay. Now, when it comes to choosing of insulin, we need to consider a lot of factors. Okay. Age, comorbidities of the patient, exercise, diet patterns, medication, alcohol consumptions. You need to consider. So we talk about individualization. Very, very important. You need to individualize the patient, because for some patients, you may not need too tight control. Okay, as we've seen in Advance, we've seen in Accord, we've seen in Vast study that older patient too tight control led to mortality. So you don't want to do that. So you individualize the patient. Some may need tight control, some you may have to relax it. Some patients are fine with A1Cs between 7 to 8%, but some patients who do very well with A1Cs even between 6 to 7%. It's case by case. So know the patient before you and what you are doing for the patient or what you have to do. Okay. Other factors again to consider, you, you can choose between premix insulin, you can choose between glargine, detamine. It depends on what, if you want to control both prandial and postprandial, okay, know that a single dose may not give you that dual effect. But where you have poor control from the onset, where the main contributing factor is coming from your fasting plasma glucose, which starts in phase 2 and phase 3 thereabout, your best shot is your basal insulin. Unless with time, as you monitor the patient, you realize that, oh, fastings are controlled, but the patient keeps having high postprandials, then you can do your basal bolus or do your premix. But please remember this, all right? Now, insulin therapy options, I've spoken about basal insulin, where you can do once or twice daily. Okay, you can do ones for glargine, you can do ones for detamine, you can do ones for some premix. Then you can do, and then there's the intermediate acting. The intermediate acting like NPH, which is a human insulin, neutral protamine, and then there's the ultra long acting like Duglidec. We have the premix insulins as well. Okay, then there's the rapid acting insulin where you can do preprandial, and then we have the combinations where you can do basal bolus or basal plus. The difference between basal bolus and basal plus is that for basal bolus, you are given short acting for every meal, 15 to 30 minutes before the person takes the meal, and then you give a long acting once a day. Okay, for basal plus, realize that for this particular patient, fastings are okay, but any time the person checks the sugars in the afternoon, the postprandials are high. You can give your basal and then give a short acting with only lunch. That becomes a basal plus. So the choice and the combinations are there. But what is important is you should know why you are choosing a particular insulin for a particular patient. Okay. And insulin replacement therapy, the whole aim is to recreate the normal blood insulin profile, the first phase and the second phase. You want to mimic that. Okay. But please remember that these phases are delayed. And as they get delayed, they get blunted and then they get entirely lost. And what you need to control or fix first is always the fasting. And that is why you need a basal insulin from the onset. With time, if things are not getting well with your insulin augmentation to the orals, then you can consider options like the basal plus, the basal boost, and all that. And remember that basal insulins also have role. Okay, we are not here to talk about use of or control of glycemia in the Ramadan or fasting state. We have other indications. Okay, so this is what basal insulin available for treatment of diabetes patient. So the neutral protamine heganon, NPH, okay, it's a human insulin. We have the analogs. We have the first generation, like glargine. We have detamine, okay, and then we have the newer generation insulin, which is ultra long acting called insulin Duglidec, okay. Now, what are the evidence? Clinical algorithms or clinical evidence have demonstrated in the past why we have to, okay, both ADA, and we'll look at what has been done in some countries. So basal insulin all over the world, the ADA, the ESD, among the Indians, the American Association of Clinical Endocrinologists, all these guidelines, International Diabetes Federation promotes the use of basal insulin. So it is not Dr. Adair saying it. I've shown you the evidence, and now I'm giving you what supports what I'm talking about. Okay. But I want us to remember something, that we have to avoid what we call over basalization. And I brought this slide because sometimes there's that tendency, there's that temptation to keep increasing the basal insulin. The danger here is that your patients may be or can record very high, very low sugars. Okay, the patient can tip into hypoglycemia. Remember when I spoke about the pentad, the glycemic pentad, hypoglycemia can be as dangerous as hyperglycemia. So you don't want to tip your patient into hypoglycemia. Usually, the dose of insulin ranges between 0.1 to 0.7 per kilogram body weight. And when you are initiating basal insulin, it is always good to initiate with zero point 0.2 per kg. Okay. Or to be on the safer side, always start with 12 international units and then you can titrate if you don't know the weight of the patient. But obviously, if you know the weight of the patient, please start with 0.2 per kg and then you titrate. You can always titrate by 2 units. Okay, you can do that based on your glucose profile. Okay, but you don't aim at exceeding 0.5 units per kg per day. Don't go beyond that. So that if 0.5 kg per day, you've gotten to that level and you are still not achieving optimal glycemic control, please consider other options. Do I have to move the patient onto premix? Do I have to do basal bolus? If the patient, let's say, on 2 drugs and you add it, should I add a third drug? Like a GLP receptor agonist, or should I add an SGLT2 inhibitor? It is very, very important. So over basalization can be very dangerous. In as much as we are educating ourselves on the use of basal insulin, please don't over basalize your patient. Okay. And remember that basal insulin affects mainly fasting plasma glucose, but not so much of postprandial glucose. It's very, very important. And over-basalization, as described, is the continued escalation of basal insulin doses to target fasting plasma glucose with no improvement in postprandial glucose and A1C targets. That is the definition of over-basalization. Please don't be caught in this web. Remember this, okay? Right. We'll quickly look at what the barriers are when it comes to insulin initiation, what we call inertia. Okay. There are several barriers among patients and healthcare providers. One of the biggest that evidence has shown is the fear of hypoglycemia. But remember that with the right dosing, patient education, this can be avoided. Okay. Fear of reduced quality of life. Patients are worried, oh, I have to carry needles with me. No, but now we have the pen fills. We have hypodermic needles where they can even put in their pockets. Okay. Reluctance to inject in public stigmatizes the perception that the disease is becoming more severe. Some will tell them, oh, when my uncle was put on insulin, he died. And it's because maybe the uncle has some advanced renal disease. So it's not the insulin, but it's advanced renal disease. All these are things that we have to know so that when we are educating, we bring the fear of needles, pain of injections. Sometimes you need to bring up the hypodermic needles for them to see. Patients do not feel empowered. They don't feel empowered. And that is why we have to start dedication okay? We have to start very early so that when we are introducing it, they wouldn't complain, okay? Again, there's a lot of evidence to show that often we fail, and that has to do more with clinical inertia, okay? And in most studies, it's been shown that when patients were on even more than one drug, it took up to 7 years before they were started on insulin. That is very, very bad, and that is dangerous. And we don't have to be caught in that web. From the UK-PDS and the DAWN study, again, there's resistance to insulin despite efficacy and guideline recommendation. The UK-PDS demonstrate 27% of type 2 patients randomized to insulin initially refuse. This is patient inertia, okay? In the DAWN trial, was shown that about 50% of type 2 patients, again, express anxiety about starting insulin. These are all inertia on the part of the patients. Now, in a survey of insulin-naive type 2 diabetes patients, 28.2% of respondents reported that they will be unwilling to take insulin. These are evidence based on inertia on the part of patient. Okay. Now, there's clinical inertia, and what I want to emphasize is we, the healthcare providers, should do the right thing. We educate the patient, but on our part, we shouldn't be reluctant. And what is clinical inertia? Clinical inertia is we having all the knowledge, but we still delay treatment initiation and optimization. That is what clinical inertia is. And if you look at the duration to which some patients were randomized onto insulin, it took a long time, and that should never happen. Okay. Common reasons we give as healthcare providers when it comes to clinical inertia. If the insulin will make the patient fat, fear of hypos, pain of needle. No, please, we need to break that inertia. Okay. And then we perceive sometimes insulin as the last resort. No, insulin is never the last resort. You can actually start basal insulin right from diagnosis. And as the patient gets better, you reduce the medications, including an insulin. So now what we preach is early intensification. We no longer do conventional or what we call sequential treatment. It is not advocated for anymore. Okay. Now let's come to the question that I started with. How long does it usually take you from diagnosis to starting insulin in your patient? Okay. Right. I hope you have the answer now. Okay. Going back to my case scenario, Madam Adjoa Mensah, with her presentation with a baseline of 10.8%, who is being optimized for surgery, what will you go for? Will you go for insulin with some orals, or you just put this patient on orals? Remember that she has very bad back, and the surgery is so important. Okay. Will you give her insulin in addition to other medications, or you still withhold insulin at the time of diagnosis? I leave the answers to you. Okay. So I'll conclude with a take-home message to all of us. Okay. The first I want to talk about is that there are enormous benefits associated with early insulin initiation, as we showed. If we're able to reduce A1C very early, we're able to reduce microvascular complications as well as macrovascular complications, bearing in mind the right dosing to avoid hypoglycemias. Okay. But hypoglycemias can be as dangerous as hyperglycemias. Okay. Very, very important. We also have to remember that a suitable regimen must be individualized to meet patient needs and outcomes, what we call treating to target. One jacket wouldn't fit everyone. We have to know the needs of every patient. Okay. The last batch one that I want to talk about is that most guidelines suggest initiation with basal, okay, or premix insulins. Very important, as shown. And then let's overcome the barriers and seek early help if need be. Okay. If you are not so well versed in how to initiate and intensify insulin, okay, you can call. There are diabetologists around, there are physician specialists around, endocrinologists around. Identify somebody you are comfortable with that you can always call for help. Okay. If you don't get anybody, you can fall on Dr. there. That is just by the way. Thank you so much for your time. I think I'll hand over to Jifa at this point. Thank you.
Thank you so much, Dr. Day. That was straight to the point, and all the important highlights were made. Fixing fasting first, what contributes to poor glucose control. That's the fasting blood glucose, and I'm glad you highlighted all that and also emphasized on over basalization. Thank you so much, Dr. Ade. We'll still be taking questions at this point. Please type your questions in the chat box. Type your questions in the chat box and we'll be taking all your questions in a jiffy. But before we do that, we will take a presentation from our rep, Seth Osuansa. I'll project his slides, then he would have the floor. Thank you very much.
Good afternoon, everyone. My name is Seth Osuansa. I'm a medical rep for Sanofi. Yes, analyst in biology. This afternoon, we will just be put on to discuss how to drive better outcomes in people living with diabetes and addressing the urgency in achieving glycemic goal. Oh, it's not.
Can the video upload?
Watching you.
Hi, Prince. Can you change the slide from your end? Oh, it said I uploaded it. Okay. Should I turn the video on for you?
Yes. Good afternoon once again. My name is Seth Owusu. I'm a medical rep and a pharmacist with Sanofi. This afternoon, I will be sharing a concise clinical overview on the importance of early insulinization with focus on basal insulin, and then how to drive better outcomes in people living with diabetes, addressing the urgency in achieving glycemic goal. I would want us to look at Chris. Chris, a 53-year-old civil servant. He's been with diabetes for 7 good years, diagnosed with hypertension for 2 years. He's on metformin, biguanide at 1 gram b with that maximal dose of that. He's also on sulfonylurea at optimal doses, some calcium channel blocker and an ARB. In spite of being on two powerful oral antiglycemics, you realize that HbA1c is still around 8.9%, not that good, with either 6.5 or 7. Fasting blood sugar is around 166 milligram per deciliter, already presented with some level of microvascular complications with the onset of numbness in his lower extremities and daytime somnolence. We are asking that, in your opinion, after exhausting two power lines of oral antiglycemics at optimal doses, what will be your next management consideration for this patient? I know before the presentation from Dr. Ada, I realized that we normally would want to start on stacking on oral antiglycemics. We exhaust the oral options before starting insulin. And we are saying that you would want to add on an option that would achieve glycemic goal, also in turn prevent complications for your patient, and then add an agent that has least with respect to hypoglycemia, either nocturnal or overall hypoglycemia. Obviously, you would want to add on an option that would achieve glycemic goal. This is to also say that with a landmark study, the therapy options were arranged. You realize that some patients were put on 3 orals and others were put on even more than two orals, and then we started insulin very early. We realized that adding more orals, more than 3 orals, do not achieve any significant benefit with respect to HbA1c. You're also saying that insulin give you, in terms of HbA1c, the effective is more effective as compared to the others with respect to HbA1c. Averagely should be having more than 2.5% reduction in HbA1c. This is to say that as of 2024, ADA guidelines should recommend that anytime we start with insulins, we start basal. We know guidelines are unanimous, so International Diabetic Federation, American Association of Clinical Endocrinologists, and American Diabetic Association recommend that basal insulin as the most initial insulin regimen in type 2 diabetes. We are saying that not only is it controlling fasting, it's giving you that holistic control. The fasting, you're fixing fasting first, postprandial will be phased, and again, HbA1c will be phased. This is say that timely initiation of basal insulin is key. Not that we will not need to wait, exhaust the oral options before starting the insulin. We start very early, create very good metabolic memory for our patient so that long-term management wouldn't be an issue. And again, we're also saying that giving an agent that will best be able to prevent complication that comes to the disease. UKPD, with the other, the inside triple therapy also buttress the point. Avoiding hypoglycemia, we know that an agent that will mimic the normal pancreatic basal insulin secretion should be good so that we don't expose our patients to risks or don't expose our patients to things that would expose them to hypoglycemia. Rather, we keep the treatment simple. We start insulin very early, and then we are able to titrate very well, and obviously we'll be able to prevent the hypoglycemia that comes with it. We are saying that we are choosing an agent that will be able to provide that peakless control of your glycemic indices. And no insulin glargine lantus being able to give you that peakless continuous release over 24 hours and mimics the normal basal insulin secretion. You are choosing basal insulin. We are saying lantus happens basal, and then it's also an ideal basal insulin to start with because it closely mimics the normal pancreatic basal insulin secretion, giving you that peakless control over 24 hours coverage of your glycemic indices. And once daily administration for patient compliance is also key. This gives you that predictable absorption pattern with half-life of about 12 to 17. So overall, it's able to cover for that 24-hour control of your glycemic indices. We would want to start insulin. We want to start Lantus. For Chris, he's already doing oral antiglycemics and not doing well. We start with 0.2 international units per kilogram body weight. So 0.2 times 70 kg, that should give us about 14 international units once daily. We are doing that together with oral antiglycemics in the clinic. Once the patient, now ask the patients to present themselves after 3 days. You check fasting, and fasting is not where you want it to be. You are allowed to intensify. We are saying that you're not only starting insulin, but you're also titrating very early and very well with the addition of 2 units every 3 days, so that we are able to achieve very good glycemic control very early in the disease management progress, and long-term management wouldn't be an issue. This is why Sanofi, we are saying that starting Lantus is as simple as 1, 2, 3. It's just 1 prick a day, 0.2 international units per kilogram body weight, and then you titrate, you intensify with 2 units every 3 days, or de-intensify with 2 units as and when. We are saying that titration is equally as important as initiation, and not only when we really want to start, but we're also saying that starting and titration is equally important. In summary, what we are saying is a basal insulin regimen is an ideal start. With Lantus is simple, gives you higher glucose lowering efficacy, as with laptop and other studies that gives about 26% greater reduction in HbA1c. Lower rates of hypoglycemia is evident with initiate and durable studies and all that. We are saying that after a patient is on control of 2 oral antiglycemics, adding a third or fourth agent does not offer additional glycemic control benefit. It is the right time to start insulins, and it is the right time to start basal. And we are saying start with Lantus 1, 2, 3. Thank you very much. Yes, so key take-home messages are patient uncontrolled on 2 oral antiglycemics. You start with Lantus 1, 2, 3. You do 0.2 international unit. You are good to go. Patient already on oral antiglycemics, also on Lantus. You know, starting 10. You start, you don't forget to also titrate. You know very well that titration is equally as important as initiation. And obviously, with our discussion we've had this afternoon, we know that all people living with diabetes should be educated, so that the clinical inertia that comes with initiating would be a thing of the past. Thank you very much for having us. Thank you. We welcome for questions.
So thank you very much, Seto Uso, for that presentation. We must apologize for the technical hitch. Sometimes these things are bound to happen. So sincere apologies, and we hope that your questions are in the chat box. If the questions can come up, that would be great. Okay. So thank you for your engagement. Thank you for being with us. And thank you for asking your questions. Our first question to Dr. Adai is from Dr. Brew, Dr. Ruth Brew. She's asking, well, she commends you, Dr. Adai, great presentation, Doc. And please, you mentioned that basal insulin can be used in pregnancy. Can you please throw more light on that? Dr. Adai, you have to mute.
Hi. Yes. Thanks, Jiva. And Ruth, thanks for the compliment. Yes, you can. When it comes to hyperglycemia in pregnancy, we now categorizes it into 3 forms. Okay. So we have what people used to call chronic diabetes in pregnancy, or pre-existing diabetes in pregnancy. We have gestational diabetes, which you first notice in pregnancy. So you first notice the dysglycemia in pregnancy, typically around 20 weeks and beyond, or what people say 5 months and beyond. And therefore, the recommendation for screening for gestational diabetes with an oral glucose tolerance test is between 24 to 28 weeks. Okay. And then you can also have another form that you may not pick within this gestational diabetes period, but then the person has been diagnosed before. Okay. So when you can pick up this glycemia in the first trimester, which means that the person might have had an undiagnosed type 2. Please, do you understand what I'm saying, Ruth? Good. In all this, you can use insulin in pregnancy, but when it comes to gestational diabetes, it's actually a form of insulin resistance due to hormonal changes. And if you look at landmark trials like the ACHOS trial and all that, gestational diabetes is best managed with lifestyle, so diet and activity level. Okay. Now, when diet and activity level fails, best drug is insulin. And in using insulin, if the person is well motivated, you can use a basal insulin that gives you a 24-hour coverage. You can use that. You can do that. Now, there's the role of metformin. And in Ghana, we use metformin a lot. There's also another role, but studies have not supported it so much, what we call glypyride, okay, which is available in the developed world. So yes, you can use basal insulin, and there are actually clinical trials to support that, okay. You can also do basal bolus in pregnancy, and it's very, very, very safe. Thank you.
Okay, we have another one from Dr. Safo. Any difference between physiological and basal insulin?
Yes, Dr. Safo, thank you. I don't know if you joined from the beginning, but from the beginning, I showed the normal physiology of insulin secretion, where I showed the first phase and the second phase of insulin secretion. So when the body is exposed to glucose, okay, you have a surge of insulin, what we call the first phase, and that happens within a minute or two, and that can last up to 10 minutes. And then following that is the second phase, which begins from 10 minutes to about 1 to 2 hours. Okay, that is the normal physiology. Now, people try to say that the second phase acts more like basal, but don't forget that the first phase ends at 10 minutes. So what the basal insulin actually controls mainly hepatic glucose output. Basal insulin will control both prandial and postprandial, but its effect is more on hepatic glucose output, because what does insulin do in the body? Insulin regulates carbohydrate metabolism, regulates protein, regulates lipids. Okay. Now, when it comes to carbohydrates, insulin does two things. It promotes uptake of glucose at the peripheral cells. So you're looking at your muscles, the liver, and adipose tissue. Okay. Insulin also promotes the synthesis or the build up of glycogen in cells, mainly the liver and then muscles. Insulin also promotes what we call gluconeogenesis from other substrates. So through the Krebs cycle, insulin can help use amino acids to produce glucose. That can happen. And then lastly, insulin will counter the effects of glucagon by inhibiting what we call um, glucose, what's the word? Glycogenolysis. Let me put it that way. Okay, right. So that is for carbohydrate. When it comes to proteins, insulin promotes uptake of amino acids at the peripheral sites. And again, insulin promotes the synthesis of protein, especially in muscles. When it comes to lipids, insulin promotes triglycerides at the peripheral levels. And then insulin is lipogenic. So it causes the synthesis or promotion of uh, lipids or storage in adipose tissue. That's how insulin, and glucagon does the reverse of all this. Okay, so that is the physiologic state. So phase 2 of insulin secretion usually will mimic the basal that we're talking about. Okay, so physiologically there are two phases of insulin secretion. I hope I've been able to. And remember that when we talk about insulin in diabetes, we talk about exogenous insulin and then endogenous. Endogenous is what the client or the patient is producing, and exogenous is what you are bringing from outside. Okay, so please don't miss the two. So we are doing basal insulin because the patient's own basal insulin is just not adequate. So you are bringing some from outside to top up. That is it. But in topping up, we try to say that don't over top up, and that is the over basalization we spoke about. Thank you.
Thank you, Dr. Ade. We have another one from Dr. Benjamin Saki. Very insightful presentation. I've learned a lot. Thank you, Dr. Saki, for your feedback. His question is, what is the role of sliding scale in the management of type 2 diabetes?
Ben, again, thanks for the compliment. You see, I'm smiling. I'm smiling because um, I want to be candid about this, okay? And sorry if I step on any toe. But in my practice, I'm close to about 10, 12 years. I've not done sliding scale in any of the patients I've managed, okay? Because the danger with a typical diabetes sliding scale that we know, it causes glucose variability. Got a typical sliding scale, you are looking at short-acting insulin, okay? And one of the slides that was shown by, if I was the name of your colleague that did the presentation, sorry.
Seth. Seth.
Seth, good. One of the slides that Seth showed, he showed how quickly the short actings will peak and then drop. You get it? And if you remember, Benjamin, the two phases of insulin that I showed, your short acting insulin will not give you that basal effect. Remember this. In sliding scale, we use short acting insulin, and your short acting insulin will not give you that basal effect that you need over a 12 to 24-hour period. So, what happens is that when you're doing sliding scale, and if you be candid about it, you realize that in your practice, you give it, the sugar goes down. The next minute, the sugar is up. So you cause glucose variability, which is as dangerous as hyperglycemia or hypoglycemia. So now, when you're managing any patient, you have to decide if the patient comes in an emergency, for example, HHS, DKA, okay, you decide. You start your hourly short-acting insulin, get the sugars down, get it to around 13, 14, thereabout. When they are around that level, now you have to decide the patient is very, very stable. And you know the baseline A1C, let's say baseline A1C is about 7.5% in a DKA, or baseline A1C is about 10% in this patient. Because the patient came in emergency, that 10% of A1C straight away, for that patient, you need 3 drugs. 2 can be oral, but the third drug should be a basal insulin at a time. So I just want to add to Seth's take home. You don't start basal insulin only by adding on to orals. No, you can actually start basal insulin at the time of diagnosis when the A1C is very high, because 2 drugs, will maximum gain you get from 2 drugs maybe between 1 to 3% A1C. But when you add on insulin, you can actually make up to 5% thereabout. So a patient with 10, in about 2 to 3 months, you would have helped that patient by dropping the 10 to even about 7% thereabout. And we do that in clinical practice. So as the A1C improves, then you can withdraw your basal insulin that you started with. Keep the patient on 2 orals. Okay. And again, as they get better with lifestyle intervention and everything, you can withdraw the second drug. So that is how we call it early intensification. You don't keep a patient presenting like that. So the decision should be taken by the time you deal with the urgent situation and control the sugars. you should have taken a decision. Will this patient do well on orals? Will this patient do well on orals and insulin? Or will this patient, maybe because of some underlying condition, will do well on only insulin? You should have taken that decision, and you should be able to implement it within some 48-hour space. You don't keep patients on sliding scale. Sometimes we hear of 5 days, patients are on sliding scale. No, you don't do that. I'm fortunate to work in a surgical center, and I'm telling you, we don't use sliding scale even in our post-ops. No. We're either doing basal, basal bolus, basal plus, or we are doing premix. You have to decide. For those who are well controlled, sometimes we do oral with basal and they are fine. You should know what you are doing, but please shy away from sliding scale. Few times, there's what we call preprandial, okay, where you can check the patient's sugar just before they eat. So then you do what we call the boluses. So then that one, you can give short acting to control the postprandial, okay? A sliding scale is outmoded and it's not recommended. Please. Thank you.
Thank you, Dr. Ade. We have another one from Dr. Abigail Lowusu. She says 64-year-old diabetic on metformin 1 gram BD and glyclazide 80 milligram morning. HbA1c a year ago was 6 and it increased to 9 with fasting blood glucose between 9 to 10. His renal function is normal. Would you advise increasing the dose of the glyclazide to a BD and monitor fasting blood glucose, add on the DAPA or start basal insulin?
Excellent question, Abigail. The only thing I didn't get from your great summary you've given is the duration of diabetes. But I guess this 64-year-old most likely would have lived with the diabetes for, let's say, 5 years and over. Okay. And if the patient is doing everything right by way of lifestyle, Abigail, I'll say that your patient is likely in phase 2 or phase 3 of type 2 diabetes. Okay. She's 64 years old. And once her beta cell is failing, so you see that A1C has increased from 6 to 9. What it means is that her beta cells are failing. And this is a candidate for basal insulinization. You don't have to wait, okay? Because she's on almost maximum dose of metformin, which is 1 gram BD. In my practice, I don't do 3 grams, never. If 2 grams will not work, I don't even go to 3 grams. Now, glyclazide, the patient is on plain glyclazide. Again, 80 milligram, that is maximum. I'll never do glyclazide 80 in such a patient because risk of hypo is very high. Okay, so what I'll do for this patient with very good renal function means that microvascular complication has not set in yet. But if we leave this patient with A1C around the 9%, in no time from the UK PDS, we know that 8.5 and above microvascular complications will set in. So this is a candidate for basal insulin. So what I'll do for this patient, because the beta cells are failing, I will either decrease the insulin secretagogue, which is the glyclazide, because what is the action of sulfonylureas? They are supposed to stimulate the beta cells to produce more insulin. Now, if the beta cells are already depleted, it means that your sulfonylurea will not work. So for this patient, you either step down your glyclazide to 40 milligram. You step down your glyclazide, sorry, I muted. You step down your glyclazide from 80 to 40. Maintain your metformin because metformin will help with hepatic glucose output, okay? But then you add on basal insulin. Don't go for DAPA. I agree, dapagliflozin works independently of insulin, but this patient is having failing beta cell function, okay? So maintain your metformin, reduce the glyclazide from 80 to 40 or take her off completely, okay? If you take her off completely, then yes, you can bring on your DAPA and still give the basal insulin. But this patient for the rest of her management will definitely need basal insulin or will need insulin in general. So that is what I'll recommend for Abigail. But that's an excellent question, and thanks for the question.
Thank you, Dr. Abigail Usu, for that question. I must say we have a lot of questions, Dr. Ade. I don't know if we'll be able to exhaust all today. Let's give ourselves a few minutes to address the questions. We have one from Dr. Joa Boateng, Dr. Zuya Joa Boateng. Thank you for joining. She says, hello, Dr. Ade. Could you kindly provide the answers to question 2 you posted before ending? My connection was problematic throughout the presentation, and I'd like to be sure of the answers. Thank you. I think on the question of, is it Adjoa Mansa? Yeah.
Yes. So again, Adra, thanks. Sorry about your connection issues, but on Adra Mansan, she was being optimized for surgery. A1C was in the tens. Okay, so definitely when we diagnosed her, we put her on 3 drugs, including a basal insulin. So we did metformin. She had no microvascular complications, so we did metformin for her, and then we did an SGLT2, and then we added on basal insulin. And within a space of 6 weeks thereabout, she was really optimized. The problem usually with this patient is sometimes when you rush them into surgery, you can still have some post-op complications because ideally, because she's hasn't been diagnosed and control has been poor by a time, ideally, the ideal situation is that you control them over 6 months before surgery. But her back pain, and she did very well. So we optimized her onto basal insulin with 2 oral drugs. And we had very good control. At our center, we don't rush patients into surgery. We make sure that you are well controlled your A1C to prevent post-op complications, unless is strongly indicated. With a second one, usually from 5 years and above from time of diagnosis, as I showed in the slide, they are around the phase 1, phase 2 thereabout, okay, and beta cell failure. And then remember that in most patients as well, even at the time of diagnosis, beta cell function, 50% is already gone. And that is why monitoring is important. You don't just put patients on treatment and you leave them. No. When you diagnose them fresh, please do self-monitoring of blood glucose. Follow them up with your A1C. Make sure that they are getting well controlled. Once they are controlled and you don't monitor them frequently, no big deal. But every new patient you diagnose, at least 2 to 4 weeks, let them come back with a profile, see what is going on. I hope, Adjoa, I've been able to answer your question. Thank you.
Okay, so we have another one, a lot of questions. I don't know if we can do it in 5 minutes, if we can address as many questions in 5 minutes. This is from Dr. Ara. Forgive me if I'm not able to mention your name, but from Dr. Ara Bapua. Okay, he says, is basal insulin same as soluble insulin we know? And does the pre-mix insulin refer to mixed insulin?
All right. Oh, thanks. I think basal insulin is not the same as soluble insulin, okay? Basal insulins should naturally be long-acting insulin. Soluble insulins are short-acting, okay? So soluble insulins typically will mimic the first phase of insulin secretion, whilst basal insulin sort of mimics the second phase or the combination of first and second phase, okay? The other thing is premix insulins, you are looking at a combination of short-acting and long-acting. So when you use premix, it immediately controls both preprandial or prandial and postprandial, where again, we use it a lot in adolescents. You can actually use it in type 1. You can use it sometimes in type 2s as well. Mixed insulin is specific. So when you talk about premix insulin, we have different proportions. We have some having 30% of short acting, some have 70% of long acting, some 50-50, and then there's the 60-40. What is prevalent on our market is the 30-70. Okay. And then we have Mextad. Mextad is specific. It's a combination of short-acting atrapid, then NPH, neutral protamine hegadon. Okay. NPH is intermediate. Okay. When we didn't have the analogs, we were using NPH as long-acting. But strictly speaking, NPH is not long-acting, is intermediate. Okay, so Mixtard, when you are using it, you cannot use Mixtard as basal. It will not give you effective control. Thank you.
Right. Thank you, Dr. Dai. We have this from Dr. Senna Mapeto. She says, when can insulin be discontinued in a patient who has achieved an HbA1c of less than 6.5%? Very good question.
All right, Senna, again, thanks for that excellent question. I'll only either, I'm not sure of the dose of basal insulin that gave us the 6.5%. Okay. What is key when you have your patients on insulin is to one, achieve control and avoid hypoglycemias. So if my patient, let's say, is on 14 units or 16 units of basal insulin and she's at 6.5% without any evidence of hypoglycemia, I'll not rush to take that patient off insulin. Because when you do that, in no time, the sugars will be going up. Remember, I gave the pathophysiologic basis for why the control is getting poor. The control is getting poor because your beta cells are failing. So your endogenous insulin is failing. Therefore, you are bringing some out to top up. Okay, so if you withhold the insulin in no time, the sugars will go up. However, if this patient has 6.5% and is recording hypos and is on 16 or 14, I'll step down the dose, I'll reduce it. Okay, but I'll not rush to withhold it. I may do it for a patient who is newly diagnosed, who I think may have achieved control, and then keep the patient on orals. So it's case by case. We don't just use the A1C to decide that, oh, the person is controlled and therefore let's hold insulin. No, other factors come into play. Is the patient having hypos? Is there evidence of beta cell failure in that patient? If there's evidence of beta cell failure, you continue insulin for the rest of the patient's life because it's an insulin problem. So if you stop the exogenous insulin, it's just a matter of time. It's like you are giving the person insulin holiday and the sugars will go up again. So Sanam is case by case. It's not just the A1C. Thank you.
Thank you so much, Dr. Senam. We have about 7 more questions, so let's see how well we can do with time. This from Dr. Moro, Dr. Malik Moro Abdul. He says, "How readily available is Lantus?" I think that is for my rep
I think
set.
Jifa, that is for your rep.
Yes, so is it affordable? Any other question relating to Lantus, Seth, you can come and have.
Yeah, so I would answer the yes. So, which time of day do you give the lantus? Yes, so which time of day do you give the lantus to your patient? In case you realize that in my presentation I said that it gives you that 24-hour coverage of your glycemic index. So ideally, any time of day should be very okay, depending if your patient can be just specific on the time of day. But some trials and some clinical trials realize that when you start at bedtime, it's very, very effective. That's when you start at bedtime. And then it gives about 3 cases where you would want to, and it's effective. Morning, and then before dinner, and then at bedtime. Realize at bedtime, it's very, very effective.
Is
And
it
again,
affordable?
yes, affordability, yes, Lantus is it's affordable in that the pen comes in 300 international units. And then if you are to use, let's say, 10 international units, that can last for a month for your patient. Currently, because of the euro is doing very well, we've had about 20% reduction in the price of our Lantus. So obviously, it shouldn't cost more than 300 cedis for the pen. That's able to last for 30 days for your
Is it
patient.
available?
Yes, it's available. Accra, almost major facilities, pharmacies, chain pharmacies, and all that. It depends, but you let me know where you are so that we'll be able to direct you to places that you can get it. Obviously, Lanto is everywhere.
Thank you very much, Seth. Okay, so some comments to Dr. Dai. This one is from Dr. Stephen Issa. He says, "Dear Doctor, this is a very wonderful presentation, and he's also learned a lot. We are glad you did." Dr. Christian Mensa also says, "Thank you, Dr. Dai. Basal insulin therapy simplified." I like that. Well done. Dr. Michael Opari also says, "Thank you very much, Dr. Deg. Please, I want to know if we have different glycemic targets for different age groups, especially for the elderly." Very good question.
Right, Mikey, I'll be quick about it. Thank you. But since you're a doctor, I'll let you do further reading. Try and get an advance, accord, and vast trial. Okay, that is what really informed. So it is not just about the elderly, but you also look at comorbids. Okay, you can have somebody 65 years old who looks like a 40. So it's case by case. However, when you have someone 60 years and above, who may have suffered, let's say, a thrombotic stroke. The person may have had a heart attack before, or there's some peripheral arterial disease. What I'm talking about is the person has some established atherosclerotic cardiovascular disease and advanced age. Life expectancy is not that good. You don't aim at tight control. No. Okay. These are patients that if you have an average A1C of even 7.5%, it's fine. You don't want very tight control. The same thing with their blood pressures. You don't want too tight control of their blood pressures because it's been shown that when you control them tightly, they rather end up having mortalities. So it's case by case. And I want you to do further reading with advanced accord and vast trial. And I'm sure you have more insight on this. Thank you.
Thank you, Dr. Dai. One last question. What happens if a patient has a random blood sugar of about 14 millimole with an HbA1c of 10? Is the triple therapy still recommended? I think sometimes the fear is the clinic random blood sugar value as against the HbA1c and the risk of hypoglycemia. This is from
Right.
Dr. G. She did not
Okay,
mention.
Dr. GA, again, thanks for the question. I don't know the context, but I'll try and address the question. So I'll take two scenarios. This can pass for a newly diagnosed patient, or two, this can also pass for a patient who's already on treatment. What this means is that the person is not properly controlled. Okay. Now, if the patient is already on treatment, let's say two oral drugs, and you are having A1C of this, all you need to do is to please augment the two oral drugs with basal insulin. If this is a newly diagnosed patient, yes, the patient will need three drugs from the beginning. Okay. If the person has no osmotic symptoms, then you can use three oral drugs for synergistic effect and you get away with it. At the time of these values where you're making the diagnosis and the person has polyuria, polydipsia, or any other symptom, you need one of the three drugs to be an insulin. You definitely need an insulin. Okay, what we call early intensification. So you do that, and as the patient gets better, but you don't leave them. These are patients that you want to see in 2 weeks with a sugar profile and see where uh, the changes are. Is she doing well prandially and postprandially? And so I've given you two scenarios because I didn't get a context of the question. Thank you.
Thank you very much. Hey, interesting. Dr. Dai, someone says, "I doff my hat for you, Dr. Dai, for the excellent presentation. The sliding scale answer was very insightful." And this is from Dr. Kwansa Nanabini. Thank you. Also from Dr. Young Samuel, I can't really mention the other one. A true, okay. Wonderful presentation, Doc. I have indeed learned a lot today. Thank you so much. Another one from Dr. Zoya Boateng. Thank you for your informative response, Dr. Adai. Much appreciated. Okay, so on that note, we say goodbye. Thank you for joining. Thank you, Dr. Adai, for being a very resourceful facilitator and for letting us appreciate your practice and appreciate your experience as well. Thank you, Seth, for your presentation as well. And thank you, Jifa, that's myself, for being a good moderator for today's session. I'm available when you have any questions. All my reps are also available on the field. We have Kofi in Kumasi and Seth in the southern sector. There are also a number of reps who represent other molecules or other products as well. So feel free to reach out to us if you have any questions, any queries, anything you want to be addressed. So on that note, from Symbiotica, from Sanofi, from Pharma Symbiosis, we say a very goodbye to you. Enjoy the day and enjoy the rest of the week. Bye-bye.